Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Feel free to ask questions in the chat box as we go along, and your questions will be addressed. So today we're going to be continuing our discussion from last week for Pulmonology Month. We are going to be basically discussing some common pathologies that we see according to the first aid book, and also going to be going over some case studies. So we are going to learn about the mediastinum. We forgot to go over that anatomy last week, and then we're going to learn about the differences between restrictive and obstructive diseases because I received a lot of questions about it last week, so I figured we could discuss that a little bit more and understand the differences in depth. And then we'll be doing some more case studies from the Amboss Q Bank. So let's start off with the mediastinal anatomy. So the mediastinum, the normal mediastinum, it contains the heart, the thymus, the lymph nodes, also the esophagus and aorta. And in the latter, and on the top right, you can see here, there on the top right here, there's actually the superior mediastinum, which is up here, which includes everything above the transverse thoracic plane, and the inferior mediastinum, which is actually everything below here. So that inferior mediastinum, that includes uh, uh, the anterior and the middle and the posterior mediastinums. And then the anterior mediastinum, that basically includes everything in front of the heart. Remember, anterior means in front of. And the middle mediastinum, that includes the heart, while the posterior mediastinum includes everything that's behind the heart. So very simple. So here you can see everything behind the heart. The middle mediastinum mostly includes the heart, and the anterior mediastinum is the space between the sternum and the heart, the in front of the heart. So there are arteries, veins, and nerves, as well as the complex branches of the heart that are inside here. But we focused on cardiology last month, where we went over a couple of these aortic branches and arteries and veins. So we're going to be focusing mostly on the pathologies in relation to this thoracic cavity and specifically the lungs. But let's talk about the superior mediastinum in depth a little bit. And I'll explain why it's so important to know that. But basically, the superior mediastinum, it's everything above the transverse thoracic plane, right? Basically everything above the sternal angle, which is on your sternum, and on the sternum there's something called the sternal angle. This is where the sternal angle is located. These are the branches of the aortic arch, if you'll remember, from right to left. You'll see the brachiocephalic trunk or the artery. There's only one of these, and then it crosses to the right branches, to the right subclavian artery and the right common carotid artery, the left common carotid artery, and the left subclavian artery, which is over here. And then the branches of the superior vena cava include the right brachiocephalic vein. It's not, actually, it is. Here's a right brachiocephalic vein, which branches to the right subclavian vein and the right internal jugular vein. And the left brachiocephalic vein, which is longer because it has to cross over to the left here, right? So the left brachiocephalic vein crosses to the left, and then it branches over to the left subclavian vein and the left internal jugular vein. And then there are nerves, right? The phrenic and the vagus and the cardiac splanchnics. They travel anterior to the subclavian artery, but posterior to the subclavian veins. So you can sort of think of it as veins, arteries, and nerves, van. That's sort of the order of how I remember it in that acronym. And don't forget that the internal thoracic artery that we learned last week, that branches from the subclavian arteries. And then also the superior mediastinum veins, of course, include the right and left internal jugular veins as well, and also the right and left subclavian veins, as we discussed already. Okay, so now I'll explain why I just went over all that anatomy, and it actually helps you put into context why you're learning all of those different veins, arteries, and pathways. The reason being is because it's actually how we figure out where to place a pacemaker. And essentially, pacemakers, they have wires that thread through the left subclavian vein, and you can see number 1 on this diagram here, the left brachiocephalic vein, number 2, and the left brachiocephalic And so there's left brachiocephalic vein, also the superior vena cava, the SVC here, number three. And then onto the right side of the right or the right atrium. And that's why knowing the complex anatomy is so important because it can be life-saving for a patient who is in need of a pacemaker for their heart function. Now let's talk about the anterior mediastinum. We said before that the anterior mediastinum is everything that's between the sternum as in the frontal bone, and the heart. There isn't actually much here, just mostly the space between the sternum and where the heart is located. And the anterior mediastinum, it holds thymus remnants. And we'll talk more about that here. So here, the thymus gland, it's a central lymphoid organ, and it makes T cells. T cells are very important for our immune function and how we respond to different diseases and infections, and it's actually how our body fights disease. It actually spans the superior mediastinum and the anterior aspect of the inferior mediastinum. It's also located anteriorly to all the vasculatures, as in like basically if you take away the thymus gland, then you can see all the vasculature I talked about for the pacemaker, but it sits on top, so it's anterior to all that vasculature. The thymus is actually almost fully developed before birth, and then it gradually involutes, as in it gradually breaks down, and it's replaced by fat about 3% at a rate of 3% per year after the age of 5. So therefore, there's like very little to no thymus left in adults. And that's why new T cell production in adults is very low. It's very interesting. It's almost like your immune system sort of, and there are actually very complex ways that happen. So basically, your immune system has made up all the T cells that it sort of needs, and that's why the thymus gland isn't as active in adults. It's more so active throughout early childhood and teens. Now, let's talk about the middle mediastinum. The middle mediastinum it contains the heart with its pericardium, which is basically its outer covering. And that's basically just the main occupant of this middle region. And remember that the heart is uniquely positioned, and that actually affects how the lungs are. So the heart is uniquely positioned such that 1/3 is to the right and 2/3 is to the left. So that actually affects the number of lobes in the left lung. That's why the left lung has one less lobe than the right lung that we talked about last week. Now let's discuss briefly the posterior mediastinum. Basically, the posterior mediastinum, it's everything that's posterior to the heart and anterior to the vertebral bodies. Vertebral bodies meaning basically the backbone, right? Those are like the C1, T1, the vertebra of it's right behind all of this. So and then in front of it is the heart, right? So basically, this area includes the descending aorta, the esophagus, the azygous venous system, the thoracic duct, and the vagus nerve. Also, with the alongside the sympathetic chain, the splanchnics, and also a lot of autonomic stuff is happening here, but I won't go into detail there. But the descending aorta that provides the intercostal arteries, which run through the third to 12th intercostal spaces of the ribs. And the last space is the subcostal artery. And then there's also bronchial arteries and the esophageal arteries. Because remember, the esophagus needs blood supply. The subcostal spaces need the blood supply, basically because there's muscles over there. And then just to explain what is the azygous system, it's just a fancy name for how basically a fancy name for how these intercostal spaces in the muscles drain the posterior body wall on the right side that's directly next to the azygous vein, and to the left of the hemiazygous and accessory hemiazygous veins, and then they cross over to the azygous vein. So I didn't put a picture here. I didn't want to confuse us, but it's just a type of venous drainage system. It's just a group of veins that like work together to circulate the blood, and then they drain the upper lumbar region and also the thoracic wall. And then there's also the supreme and the superior intercostal vessels, and they supply and drain the upper intercostal spaces. And then the thoracic duct that lies between the descending aorta and the azygous vein. right here, the thoracic duct right here. That's posterior or behind the esophagus, and that carries lymph from 3/4 of the body, aka everything that's below the everything below the diaphragm and the upper left half of the body. And the right lymphatic duct actually drains the remaining upper right portion of the body. So it's not half-half, it's actually 3/4 and 1/4, the division between the right lymphatic duct and the thoracic duct. So remember the right lymphatic duct that drains less amount of lymph because that just drains the upper right portion of the body, whereas the thoracic duct drains 3/4. So remember, right lymphatic duct less, thoracic duct more. Now, the thoracic and the right lymphatic ducts, they basically empty at the venous angle. That's basically an anatomic region. That's the junction of the internal jugular and subclavian veins. It's like this V shape, basically, by your subclavian vein. And that's called the venous junction. And the vagus nerves, they pass between the subclavian artery and vein, and they give rise to the recurrent laryngeal branches, which include the left recurrent laryngeal curves underneath the aortic arch, and the right recurrent laryngeal underneath the subclavian artery. So I'm not really showing you all of that complex vasculature. I'm just trying to give you an idea of how complex it is. It's not just one diagram, it's a lot. But the vagus nerves, they then travel to the gastrointestinal tract and they are put in contact with the esophagus and the left vagus. Um, yes, the left vagus nerve, and that moves anteriorly, or the anterior vagal trunk, and the right vagus nerve moves posteriorly, so towards the posterior vagal trunk. Now that we have like basically a broad understanding and a brief overview of the mediastinum and what should normally be happening there, and in the healthy person, let's actually learn about some of the common pathologies that actually occur in the mediastinum. So remember where we are, right? We're in between the sternum and what was this called again? The vertebra, basically. So if we remember that the mediastinum is the cavity or the space between the lungs, we need to know about some of the pathologies related to it because it can actually affect the lungs as well. So for example, like a lymphoma or a lung cancer or abscess, they can occur in any compartment, but there are some very common associations, you could say, of each of these areas have more of a frequency. Now, we don't actually know why sometimes, like for example, a thyroid of course we understand why here because of the location, right? But for example, like the middle has more malignancies than the posterior, but that's probably because the posterior side actually has a neurogenic tumor and a enteric cyst. So just to explain let's go front to back. So the anterior side, there's this mnemonic to try to remember it essentially. There are 4 T's: the thyroid, the substernal goiter, thymic neoplasm, teratoma, and also the terrible lymphomas. They all mostly occur in terms of mediastinal masses towards the anterior mediastinum. The middle mediastinum has more metastases, has more hiatal hernias, and also bronchogenic cysts. And the posterior side can have like esophageal cancer, where that's where the posterior mediastinum it has the esophagus, and it may present as a mass in or spread to the middle mediastinum as well if it's an esophagus or esophageal cancer. And then also a lot of neurogenic tumors can also occur, like a neurofibroma and also multiple myeloma. And that makes sense because what else is here? The spinal cord. So it would make sense that we're basically form follows function. And there's another picture basically kind of showing you the anterior, middle, and posterior masses and what things normally occur. So remember here, this is where most the spinal cord lies. So that's usually why it virtually always has a neurogenic origin if there is a mass here, and most likely masses are referring to cancerous masses, but it can be other types of masses as well. Right? They can be like soft tissue, fat, or water, different masses, and also maybe like a lymph node expansion, which could be a different type of mass. All right, hope that makes sense. It is, again, just a brief overview just to sort of understand where we are in the body and what things can go wrong. Now let's talk about another type of disease related to the mediastinum called mediastinitis. Now, mediastinitis basically has clinical, remember, itis is referring to inflammation. So this is actually inflammation of the mediastinal tissues. It's commonly due to post-operative complications of cardiothoracic procedures, which occur less than 14 days after that procedure, and also can can be due to like an esophageal perforation, or any like continuous spread of any retropharyngeal infection. So the clinical features include fevers, tachycardia, leukocytosis, chest pain, and sternal wound drainage. But essentially, chronic mediastinitis is also known as a fibrosing mediastinitis. It's characterized by the increased proliferation of fibrous and basically collagenous tissue in the mediastinum. Now, we'll learn about collagen a little bit more in our sort of biochemistry preclinical month next month. I'm excited to sort of teach you all how is collagen formed, what type of soft tissue is it, but we won't get into it for now. But basically, the exact cause of because listen, so I talked about the mediastinitis, but there's also something called chronic mediastinitis. And chronic mediastinitis, you can see here in the second bullet point, the exact cause is unclear, but a lot of studies have actually shown to suggest that Histoplasma capsulatum is a potential common cause of chronic mediastinitis. You can see here how that happens is basically it's a microbe that's inhaled from fungus that's in the soil, and if it gets into the trachea, it can actually proliferate the lungs, and this is sort of what a histoplasma would look like, and this is how you would know and to diagnose it. This is why pathology is very important to know, because someone just is presenting with fever, tachycardia, leukocytosis, and chest pain. That could be a lot of different types of diseases. It can be a wide range of differentials. So how to differentiate that? You do diagnostic studies and narrow down your differential diagnosis. So again, the clinical features of mediastinitis include like retrosternal or back pain, subcutaneous emphysema in the neck and face. There's also, again, like I said, fever, tachycardia, tachypnea, the sternal wound drainage. After, like, let's say someone just has like a chest surgery, they might have some extrasternal wound drainage. There could also be superior vena cava syndrome, where someone just has basically a mass. It's a very enlarged superior vena cava. Remember where the superior vena cava is located. That's why knowing anatomy is very important. There could also be obstruction of the upper airways, pleuritis, pericarditis, and then there could also be bacteremia that leads to sepsis and also other signs of shock. Now, how would someone diagnose mediastinitis? Well, you can see on the right hand, there's a chest X-ray, and that basically shows a widened mediastinum here, and a mediastinal emphysema. You could also do a CT neck and chest in case the chest X-ray isn't too clear, you're not able to tell. But basically, the CT neck and chest would also confirm the diagnosis by showing like the attenuation of mediastinal fat, as well as mediastinal fluid collections and gas. The CBC, of course, you want to be able to tell if is there leukocytosis. That could also be an indicator. CBC, remember, CBC stands for complete blood count, which is a blood diagnostic lab study. And there you could also do, let me fix my Zoom. So you also do blood cultures, which include a blood tissue or fluid culture. That culture could also cultivate like a histoplasma capsulatum that could also be indicative of a mediastinitis. And you'd also be able to tell if there's an infection going on, you'd be able to tell what was the cause, what type of organism was it. There's a lot of microbes turning around. So how would you sort of manage it? I'll go briefly about management. You need, of course, if there's an infection, you would want to treat it with antibiotics. This is a bacteria, so you would treat it with broad spectrum IV antibiotics. And it would also depend on the underlying cause, right? It's based on the cause. Based on the cause, then you would manage it accordingly. So there are different treatment protocols for like if there's esophageal perforation, and then you would develop a specific you would decide on what type of antibiotic therapy should be prescribed to your patient, especially if there's a deep infection.
Manahil is Dr. Shima. So pretty quick. So you mentioned histoplasma, right? So I would like to just correct, is a histoplasmosis basically the lung infection caused by the breathing histoplasma. It's a fungus. and it is in the parts of the United States and different part of the world as well. And so these are the fungal spores. Basically, when we breathe in, goes in the respiratory system and cause the infection. I just want to make the correction there.
Okay, thank you, Dr. Chima. I think I mentioned that before you joined, that there's fungus in the soil and you breathe that in, and then you can see here how it could get into the lungs and cause infection. A couple of complications of mediastinitis include obstruction of major vessels and airways, pericarditis and pleuritis if there is contiguous spread. Also, superior vena cava syndrome, like we mentioned before, that expansion to superior vena cava, and also bacteremia that could lead to sepsis, which is a medical emergency for the patient. So it's very important to diagnose this early on, and to prevent significant morbidity and also prevent mortality in patients, and especially if there is chronic mediastinitis. Now let's talk about pneumomediastinum. Now a pneumomediastinum, basically, I wanted to be able to show you all. Let me screen share again really quick because I wanted to show you what a normal chest X-ray would look like. So let me actually fix that. I'm just trying to pull up the normal chest X-ray so it's easier to tell the difference between the three different chest X-rays I wanted to show you all. Thanks for bearing with me. Okay, now I'll pick slideshow. There we go. Wait a second. Okay. I'll just share this screen then so it's clear. Oh, okay, let's see this and then. Okay, can everyone see my screen? Okay. So basically, a pneumomediastinum, this is a normal chest X-ray. So this is just, I have this here so we can sort of compare to what's not normal. So a pneumomediastinum, I put in blue pneumo. What does pneumo mean? If you think of pneumonia, there are other diseases with the word pneumo in front of it. So, right. So pneumo means presence of gas, usually in the mediastinum. It can be either spontaneous due to the rupture of the pulmonary blood or secondary to trauma, or there's a syndrome called Boerhaave syndrome, and that syndrome can actually mediastinum. So again, it's just the presence of air in the mediastinum, and the most common cause is spontaneous or primary spontaneous pneumomediastinum, which actually results from if there's any alveolar rupture. Remember, we talked about the alveoli in last week's lecture, and if that ruptures, that could lead to a sudden increase in alveolar pressure, which could lead to extra air. So there could also be secondary mediastinum that can occur during like mechanical ventilation or surgery, or any diagnostic procedures. Or it could also be as a result of like chest trauma or a severe asthma attack. And less commonly, less commonly like pneumomediastinums can actually be caused by tracheal, bronchial, or esophageal rupture. And after esophageal or after alveolar ruptures, the pathophysiology of this disease, basically air would rupture through this bundle called the peribronchovascular bundle to the mediastinum. And injury to the tracheobronchial wall or esophagus can actually cause air to leak directly into the mediastinum. And continuous air leakage into the mediastinum can actually result in the extension of air that spreads into the neck and also other subcutaneous tissue like subcutaneous emphysema, the pericardium. That's why you would call it a pneumopericardium. You could also go to the pleural space, and that's when you would call it a pneumothorax, right? That's something we hear often. That's very common, pneumothorax, or into the abdominal cavity, and that would also be called a that would be called a pneumoperitoneum, but it's a pneumomediastinum. So gas can also come from gas-wearing bacteria that infect the mediastinal soft tissues as well, and that is referring to mediastinitis that we talked about before in the previous slides. So the clinical features include a chest pain, dyspnea, voice changes, subcutaneous emphysema, and also a positive Hammond sign. And we'll talk about it a little bit more. But basically, a Hammond sign essentially is when you are auscultating or listening to the heart, the chest. You would hear a specific sound, and we'll listen to that sound shortly. But I'm actually going to show you how there are some other symptoms, like there could also be chest pain, which worsens with respiration upon changes of the body position. There could be dyspnea or neck discomfort, and also crackles on compression of the neck and the supraclavicular region. So if there is air that has entered the tissues of the neck. Or there could also be Hammond sign, and we'll listen to what that sounds like if you were listening to this patient. So here in this first chest radiograph, you can see air. There's air here beneath the diaphragm. And they reveal actually linear radiolucent areas here along the left margin of the cardiac silhouette, and sometimes also the continuous diaphragm sign. And that's basically let me see here. So basically here the presentation pneumomediastinum would have you can see here there's extensive air leakage with the white arrows. This is called air leakage here. You can compare to the normal chest x-ray. It does not look like the normal one. The normal one is clear. But here you can see there is difference with the white arrows, and also there's a subcutaneous emphysema indicated by the red arrows here. And the pneumopericardium itself is indicated by the blue arrows. Remember, the pericardium is basically a sac that protects the heart, and it's basically inside, basically contains the heart. So here you can tell that there's a pneumopericardium because there's a gap in between the pericardium and the heart. Otherwise, usually the pericardium would be aligned with the heart, where you can see here, but whereas here, there's like a gap here, and that's actually filled with air. So that's called a pneumopericardium. But the pneumomediastinum here is indicated by the white arrows. Remember, this is the mediastinum area. This is the pneumopericardium. And the black area here, this is called a pneumoperitoneum. When I talked about it before, when there's air in beneath around the abdominal area. So now let's listen to a Hammond sign and hear what it sounds like. So I'll play it for you. It sounds like, well, it sounds basically, it's described as crepitus on cardiac auscultation. So was everyone able to hear that? Okay, good. All right, so now let's move on. It's just a very interesting clinical correlate. Like that's basically what you would hear, and now you know the pathophysiology, the clinical features, if they all match up, then it's likely that this patient has a pneumomediastinum even before getting the chest X-ray back to confirm your diagnosis. So now let's talk about obstructive versus restrictive lung diseases. I talked about this a little bit last week, but there was some confusion, so I wanted to make sure I got this clear and go into some depth. So remember, we talked about the spirometry. And the spirometry, there is total lung volume, the lung capacity, etc., right? So basically, there are conditions that, as you might expect, like they obstruct a patient's ability to exhale air from the lungs. That's an obstructive air disease. So if patients are struggling to get air out, the trapped air can actually affect the lung volumes and their total lung capacities. So the typical symptoms include wheezing, coughing up mucus, persistent cough, tightness in the chest, and also shortness of breath. And I'll redefine what these acronyms stand for again in the next slide shortly. But among the most common diseases in this category of obstructive disorders are COPD, or chronic obstructive pulmonary disease, asthma, bronchiectasis, and also cystic fibrosis. Cystic fibrosis is considered an obstructive disease, I know last week I talked about it being a restrictive disease. So I wanted to correct that because actually it's only sometimes in cases of chronic cystic fibrosis, only then can obstructive disorders sometimes become restrictive disorders. But in this case, if it's like a newly diagnosed cystic fibrosis and it's not chronic, it would be considered an obstructive disorder. COPD is typically caused by tobacco smoke or other air pollutants, and they almost affect 16 million Americans. So it is very relevant to know the difference, also its application. Plus, there are many more Americans that have not been diagnosed with COPD that include other lung conditions like emphysema and chronic bronchitis. And there are also examples of how like an obstructive respiratory disease can work. So without like treatment or lifestyle modifications, COPD is actually very progressive, and that can actually gradually cause someone's lungs, the patient's lungs, to lose their natural elasticity and overexpand. And that's bad because that actually prevents someone from being able to breathe out and always have like a lot of shortness of breath. So eventually, like some air will be trapped in the lungs during this exhalation. And sometimes people with a obstructive pulmonary disease can actually have an exacerbation or worsening of their symptoms that would require like emergency attention. So they'd be rushed to the ER. And this scenario would require like intubation, preceded by suction to clear the airway of excess mucus or sputum, because the air isn't actually getting it out properly. So it's a big blessing when that our lungs are clear and we're able to breathe in and out. Now, respiratory diseases, on the other hand, they're the opposite of obstructive respiratory diseases, because restrictive respiratory diseases, they prevent a patient's ability to get air into the lungs instead of out. So instead of overexpanding the lungs, the lungs volume and capacities actually shrink and reduce. This is actually due to the stiffness inside the lung tissue or the chest wall cavity. So the restrictive diseases can also be further broken down into two types. There's intrinsic and extrinsic conditions. The intrinsic conditions actually stem from lungs that like pulmonary fibrosis, um, and other conditions that actually that are caused by inhaling like dangerous pollutants. And there's also extrinsic conditions that are caused by issues that occur outside the lungs, like basically like obesity, scoliosis, and pleural effusion. So how I remember extrinsic versus intrinsic is basically extrinsic conditions are not the lungs' fault, but intrinsic conditions are the lungs' fault. So symptoms for restrictive disorders include shortness of breath, which is similar to obstructive, wheezing, and also a persistent cough. But depending on their specific diagnosis, a patient's cough can include excess mucus, or they may experience excess fluid in their lungs, pneumonia or advanced lung cancers or advanced cystic fibrosis. And again, like a crisis scenario might necessitate a suction and intubation to protect the patient's airway. So now we're going to learn a little bit more about the diagrams and the basically more of the difference in what RVF or CTLC, et cetera, stand for. So this diagram basically illustrates the flow volume loops associated with lung function parameters. So PFTs is an acronym you'll hear a lot in a pulmonologist's office or in the hospital. PFT stands for pulmonary function test, which is a diagnostic test used, and there are actually a bunch of different diagnostic tests that are used that include spirometry or and they assess these different flow volume loops to be able to tell what is the function of your lungs. That's pulmonary function test. And they actually there's like associated parameters. So here's the normal, here's obstructive, and here's restrictive lung diseases in flow volume loops. So the RV here, the residual volume. Remember, residual volume is the volume of air remaining in the lung after maximally exhaling out, or after the lungs do their maximal exhalation. FRC stands for functional residual capacity, which is the volume of air that is present in the lungs at the end of passive expiration and the end of passively breathing out. TLC stands for total lung capacity, of course, and that actually is the maximum volume of air the lungs can hold. And remember, I'm just reviewing this from last week's material, so I have this more in depth in last week's video if you want to refer back to that in case you don't remember. FEC, one, there's a smaller superscript, a subscript here. So FEC1 stands for forced expiratory volume in 1 second. So over time. This is actually the volume of air that can be forcefully exhaled in 1 second. And FVC is the forced vital capacity, and that is the total volume of air that can be forced, basically forced outside. So the total volume of air that can be exhaled forcefully after a full inhalation. And so we do there's this there are a lot of equations that you can do with this, but this is how you would find the flow volume loop if you do FEV1 or the forced expiratory volume or per in 1 second divided by the forced vital capacity or FVC, and that is expressed by percentage. So usually in a normal patient, it would be 70%, but it would be decreased or less than 70% in obstructive lung diseases. And you would be able to tell because FEV1 is decreased more than FVC, and FEV1 in restrictive lung diseases are decreased proportionally to FVC. That's another way you can tell. So that's why this fraction is very important to know basic mathematic parameters and how proportions work, because it would increase or be normal, in more than 70%, or be normal, right? Because normal is the 70%. So if you have 80%, you can't necessarily rule out a restrictive lung disease. You have to tell if it's decreased from normal if the loop shifts to the right. So in a normal full volume loop, the loop has like a typical shape of a steep rise to peak flow and then a linear descent. You can see your steep rise, then there's peak flow, then linear descent. And linear meaning like a line, right? A normal line that goes down, and with the consistent slope. And and here you can see your FEV1 is greater than 80% that's predicted, as you can see here, and an FVC would be greater than 80% predicted, FEV1, and that's calculated from this PFT as in an office outpatient. And FEV1 divided by FVC would be greater than 70%, and then all the residual volume, so lung capacity, FRC would all be normal within normal range. And then in obstructive lung diseases, you can see here there's this comparison in dotted line. This is normal. It's good to know what's normal in order to know what is abnormal. So the flow volume loop here, the loop actually shifts to the left. That indicates that air is trapping and is increasing the lung volumes. And this descent is more concave, as you can see. It's not linear, it's a concave descent. And that actually reflects obstructive airflow during expiration or breathing out. So the FEV1, it's much more decreased than and FVC is also decreased, but FEV1 is much more decreased than the FVC. And then the residual volume, the FRC, and the total lung capacity, they all increase due to the air trapping and the hyperinflation. Whereas on the other hand, in restricted lung disease, you see it's all decreased. So here you can see the loop actually shifts to the right, and that indicates reduced lung volumes, and the shape is similar to normal, right? You still have that linear, that steep peak, and there's a peak, and there's a decrease in linear, but linearly. That's why there's decreasing proportionally. But it's overall all decreased, right? The maximum volume here has definitely decreased. So everything's sort of smaller. It's a bit of a smaller version of what your lungs are normally supposed to be able to do. So in summary, in obstructive lung diseases, there's an increase in the residual volume, FRC, TLC, and there's significant decrease in the FEV1 and the FEV1 to FVC ratio, whereas in restrictive lung diseases, there's a decrease all across the board in the RV, FRC, and the TLC. And both FEV1 and FVC are reduced proportionally, and that's actually why this linear line stays consistent. It's just smaller. So the ratio remains normal or is increased, and that's why you can see here it's just normal, but it's a smaller amount that's being able to be expirated. Now let's actually go into depth of the different specific types of obstructive lung diseases that fall into this category. Now, this isn't going to be an exhaustive list for time purposes, but I'm going to be hitting on the main ones that just to get your toes, but just to understand a little bit more about obstructive lung diseases and how they work, and you can find their commonalities as well. So COPD, it is the most common obstructive lung disease. Chronic obstructive pulmonary disease is in the name as well. So COPD is a progressive disease that we talked about before. It's characterized by obstructed airflow from the lungs, and it actually includes subconditions, chronic bronchitis and emphysema. There are two types of COPDs, and it's most often due to tobacco use, which is the most important risk factor. Pollutants or also allergens, that's also a thing, also genetics. Based on, not everyone is allergic to the same things, or some people don't have allergies. That it also includes chronic bronchitis and emphysema, I said before, which often like they can coexist. And what makes COPD worse, or what can exacerbate COPD, and that would mean someone needs to go to the hospital. Basically, the exacerbation means that there's acute worsening of the symptoms that's already listed here: shortness of breath, chronic cough with mucus production, frequent respiratory infections, and fatigue. So there's acute worsening of symptoms, often associated with viral or bacterial upper respiratory tract infections. And how someone would diagnose it is actually through a spirometry, and that would measure your lung function, also imaging, and arterial blood gas analysis. So I see there's a question in the chat asking, what can cause cystic fibrosis to become a chronic condition? Actually, that's a good question. I'm going to get back to you on that. Actually, cystic fibrosis can become chronic just from how long someone has the disease, because there's actually a cure out now for cystic fibrosis, and so it would cure it, right? It would not stay chronic. And chronic cystic fibrosis is also considered poorly managed cystic fibrosis as well. So if it's poorly managed, it would become chronic, and the symptoms would become more and more advanced, because if it's not being treated, or if someone's not able to afford the treatment, then it could actually lead to becoming more chronic. If there's another answer, I'll get back to you and email you as well. Now let's talk about asthma. So, asthma is a chronic inflammatory disease of the airways that causes episodes of wheezing, breathlessness, chest tightness, and coughing. I'm sure many of you might know someone who had or has childhood asthma. Growing up, I remember I had a couple of classmates who had asthma, and their triggers were pollen back when I lived in Florida. So this intermittent type of obstructive lung disease is like most often triggered by allergens, or viral URIs, also stress. It's also associated with like or gets worsened by NSAIDs or aspirin related respiratory diseases. There's also it's also involved with nasal polyps. And there's also something called COX, or COX inhibitor sensitivity. And that's a specific type of a molecular abnormality that happens and leads to a leukotriene. That's a very specific molecule and out of scope for this lecture. But how would be clinically diagnosed is through intermittent episodes of dyspnea or shortness of breath, coughing, wheezing, and also tachypnea, or increased heart rate. And the diagnosis would be supported by spirometry. In the spirometry, you would see an obstructive pattern flow loop with a bronchodilator response, but it may be normal when not in exacerbation. And there's also something called a type 1 hypersensitivity reaction, and this is sort of getting us into the world of immunology. But that type of hypersensitivity reaction can also cause asthma. And it can actually lead to smooth muscle hypertrophy and hyperplasia. And there is also something called hyper-responsive bronchi that can result from multiple asthma attacks. But it can actually lead to, but there's also, it would actually decrease the amount of reversible bronchoconstrictions that could happen, because remember, through asthma attacks, you take an inhaled corticosteroid to sort of expand the airway and make it like a normal one. And once it constricts, you take a corticosteroid to try to improve that. Basically, someone actually a very good analogy when I first learned about asthma is like asthma is like feeling like you're breathing through a straw. So basically in class, this is back in high school, my teacher made us all breathe through straws, and that's actually how it feels like during an asthma attack. And you can see here in E, this is actually in figure E. This is an example of mucus plugging that is happening. So you can see here, these are the mucus bubbles here at a cellular lens, and what you would see in histology of someone with asthma. Bronchiectasis is also a type of obstructive lung disease. It's basically characterized by a permanent dilation of the bronchi. You can see here, this is normal, but this is permanently dilated, often due to an infection or inflammation, or you can see there's excess mucus there. It's most commonly associated with cystic fibrosis. So this is actually why it's very interesting actually, because it is associated with cystic fibrosis. And I know cystic fibrosis is basically a disease that we learn a lot about in undergrad because of the CFTR gene mutation. But we will get into a little bit more. It is that and the bronchiectasis is actually why cystic fibrosis is considered a obstructive lung disease. And it's characterized by like a chronic cough and daily purulent sputum production. And is often associated with recurrent pulmonary infections. Again, cystic fibrosis patients also have recurrent pulmonary infections. It's also confirmed by imaging and is demonstrated and by demonstrating basically an airway dilation and bronchial thickening. It's also supported by the PFD obstructive pattern flow loop. And the initial insult, basically, of the pulmonary infection combined with obstruction or impaired clearance would lead to a dysregulated host response, which would lead to bronchial inflammation and then permanently dilated airways. So it is kind of like a domino effect. And there are many causes, including airway obstruction, like a foreign body aspiration or a mass. If there's a poor ciliary mobility, remember the cilia are very important in our lungs, and that could be due to like someone smoking a lot of tobacco. It also could be due to cystic fibrosis. It could also be due to a pulmonary infection as well. So, to answer your question, Maria, actually, I would say most of the time you would classify cystic fibrosis as an obstructive lung disease. But if it becomes very chronic, very rarely it can transition over to a restrictive lung disease as well. And this is actually an example of what someone would basically this is actually a coughed up mucus plug actually, that someone could see of someone with bronchiectasis. So it's very interesting. Now let's talk about a couple of restrictive lung diseases before getting into our case studies for today. Um, let's talk about sarcoidosis. So sarcoidosis is a chronic inflammatory disease that's characterized by the formation of non-caseating granulomas. And non-caseating granulomas are very high yield in med school pathology step one exams. Love talking about it, testing about it because it basically combines a lot of different organ systems, and you can find granulomas in a lot of different places. But basically, there are non-caseating granulomas. I didn't really show the image of it because it's out of scope for this lecture, but it's just something to keep in the back of your mind. Okay, I've heard of the word granuloma before, and so it applies in sarcoidosis, and it's most commonly in the lungs and lymphatic system. And the exact cause of sarcoidosis is unknown, but it's believed to result from an exaggerated immune response to an unknown antigen in genetically predisposed individuals. And as for the epidemiology, it typically affects young adults who are aged 20 to 40 years old. There's a higher incidence in African Americans and also Northern Europeans, and it's slightly more common in women. The pathophysiology of sarcoidosis, of course, we've talked about the formation of non-caseating granulomas due to an exaggerated T helper cell response or immune response. And the granulomas can resolve or lead to fibrosis, impairing the organ function. And the clinical features of sarcoidosis include, like in the respiratory system, like include like dry cough, dyspnea, chest pain, wheezing, and constitutional symptoms are basically general symptoms, which include fever, weight loss, fatigue, and night sweats, which are very general. They can indicate a lot of different things on your differential. Cutaneous symptoms, which include erythema, lupus pernio. It can also affect the eyes. You could have uveitis, conjunctivitis, and also dry eyes. It can affect your heart. You could have cardiomyopathy, so heart block or an arrhythmia. And it can also affect you neurologically. There are also some brain complications associated, including cranial nerve palsies, meningitis, peripheral neuropathy. It can also affect your musculoskeletal system, causing arthritis, joint or bone pain. There's also hepatic and splenic complications or symptoms that can be associated, which basically include hepatomegaly and splenomegaly. And what do those mean? Hepatomegaly means an increased liver size, a bigger liver, and splenomegaly basically means a bigger spleen. And the reason why spleen would get bigger is actually because it's one of the organs in the immune system that's used. It's a secondary or yeah, secondary immune organ, but that's for our immune system lecture. So as for diagnosing a sarcoidosis, there's imaging, of course. You can see in the middle, there's a chest x-ray here. There's actually a bilateral hilar lymphadenopathy and interstitial infiltrates here. And you could also diagnose this with a high resolution CT that would actually better characterize the lung involvement if there is any in the sarcoidosis. You could also do some laboratory testing, which include ACE levels. ACE stands for angiotensin converting enzyme. There would actually be an elevated serum ACE level for someone with sarcoidosis. They could also present with hypercalcemia, which basically means an increased amount of calcium in the blood, and hypercalciuria, which basically means increased calcium in the urine. Someone can also do a biopsy, although that is very invasive of the lungs, and they would find if in here to see the scarring granulomas in the lung. If they took a biopsy, you would actually be able to see granulomas found in the affected tissues of the lung. You can see down here is actually like if someone goes untreated or someone didn't have an early detection or diagnosis of the sarcoidosis, it can spread all over the lungs. And pulmonary function tests can also be involved in diagnosing sarcoidosis, and you would find a restrictive pattern in your PFTs. So you would see a decreased total lung capacity, a decreased FVC, and a normal or increased FEV1 to FVC ratio. And if you wanted to treat sarcoidosis, if it's mild or asymptomatic, you can just observe the patient and it can spontaneously resolve. But if it's symptomatic and it progressively worsens, then you would actually want to use corticosteroids as the first line of therapy. Also, immunosuppressive agents like methotrexate, azathioprine, and some other steroids you can use. Also like hydroxychloroquine for cutaneous hypercalcemia symptoms. And the prognosis for sarcoidosis, basically, like what is life like for someone with sarcoidosis, and do they get better? So the prognosis, it varies. Many patients do experience like spontaneous remission, while others can develop chronic disease with significant organ damage. Like I said, it affects your eyes, it affects your liver, it affects your spleen, your lymph nodes, your constitutional symptoms of fever, fatigue, and weight loss. The joint and bone pain also affects the skin. So it's very broad ranging. The pulmonary fibrosis and cardiac sarcoidosis can lead to morbidity and mortality if it's actually affecting the lungs or the heart. So that's why I wanted to bring it up in the pulmonary lecture, even though it affects many other organ systems. Now let's talk about
Minahil, pretty quick, as I know Mari asked a question, what can cause cystic fibrosis to become chronic condition? And I know you already addressed in the chat box. And I will add on pretty quick that first of all, we need to know cystic fibrosis is an inherited disease. And what's the cause? It's caused by the mutations in the gene that is called the cystic fibrosis transmembrane conductance regulator, called CFTR. So this CFTR gene provides the instructions for the CFTR protein. So the persons who inherited 2 copies of the mutated CFTR gene will have the cystic fibrosis. And why patients have chronic condition? Because as you mentioned, there's a thick mucus that it produces can clog the airways, and that can lead to bacterial infection in the lungs. And these infections, when happens, can cause inflammation, they can cause scarring in the lungs and other organs as well, and which lead to the permanent damage. And this damage can include, as we mentioned, symptoms, chronic cough, respiratory failure, sometimes hemoptysis, means blood in the sputum, sometimes pneumothorax, there's a fibrosis, it can be cyst. So basically, cystic fibrosis can make patients more susceptible to other chronic infections as well, as such as bronchitis, lung infection, pneumonia, nasal polyps, and bronchiectasis. So that's a reason patients with cystic fibrosis have the chronic condition. I hope I answered. Maria will understand why it caused the chronic conditions. Thank you.
Thank you, Dr. Shima. Yes, we received some questions about that as well in the email. So that's also why I wanted to make sure that we understood that it's an obstructive lung disease. So let's talk about the last type of restrictive lung disease that I wanted to go over for today. It's called a mesothelioma. So a mesothelioma is a malignancy of the pleura that's associated with asbestosis. Asbestosis. So it's spelled Asbestosis. So I'm not pronouncing it correctly. It's asbestosis. There, that's correct. It may result in hemorrhagic pleural effusion or exudates and also pleural thickening. And it's basically a type of cancer that develops in mesothelial cells. You can see here. And the most common type is pleural mesothelioma that affects the lining of the lungs, but it can also occur in the peritoneum or the abdominal lining, and also the pericardium, which is the heart lining. The epidemiology of mesothelioma is actually rare. There are about 3,000 cases per year in the United States. It is more common in men than women, and more cases occur in adults over the age of 50 years old. The cause of this, like I said, asbestosis. Now, it's because of asbestos exposure. That's the most significant risk factor. And also exposure to other carcinogenic fibers, like there's something called erionite. And there could also be genetic mutations, like the BAP1 mutation, that is also carcinogenic for a patient, and also radiation exposure. Clinical features of a mesothelioma actually include a long latent period. Like sometimes symptoms appear like 30 to 50 years after exposure, which is very interesting. That's also why we would see asbestos cases when there was more asbestos in late 60s, 70s, and then patients would get diagnosed in the early 2000s. And so that's how we knew this is not good for us. There are also constitutional symptoms like fatigue, weight loss, fever, night sweats. So again, the same types of symptoms that we're seeing recurring. How are you able to tell this is a mesothelioma and not a sarcoidosis, because it also has fever, night sweats, and fatigue. So through other symptoms, of course, as well. And there are different types of mesotheliomas, but I'll focus on the pleural mesothelioma, which is related to the lung cavity. There would be dyspnea and non-pleuritic chest pain. There would also be dull percussion. Now, what is percussion? Basically, you take tube and you just percuss, you tap, and then on the patient, you just sort of tap, and you feel, is it dull, or do you feel a louder sound? And you learn that through med school, and that's sort of the clinical skills that you learn there. You learn that there's dull, if you do see that there's dull percussion and there's absent or reduced breath sounds on the affected side, that could also be an indication of a mesothelioma, and also a non-productive cough. How would you diagnose it? Well, of course, you see on the right hand, I give you one answer, the chest X-ray. It's often the first step to figure out what's going on. And you could also do a contrast enhanced CT if you're still not sure, because it does look similar to other types of CT scans. But there are radiologists who are very adept at training, with their training, to be able to tell what type of diseases they are. And of course, the CT scan is the most sensitive for diagnosing it, and you would find actually multiple nodular pleural lesions, pleural thickening, also pleural effusion, thickening of the interlobular fissures. You'd also find like pleural opacities and signs of local tumor growth, and also invasiveness. So that's also what you would find on a CT scan, and you wouldn't really see that on a chest X-ray. Um, There's also pleurocentesis and pleural fluid analysis that you can do. That's actually indicated for patients who have pleural effusion, basically fluid in around the lungs and suspected mesothelioma. Now, did want to talk about this a little bit since we're talking about it now. Pericentesis. How does one take fluid out of the 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 middle part of your body, right? So how you do that is actually, remember we talked about, I'll show you here, um, in the mediastinum, there is a space between the heart and the sternum called the anterior mediastinum. And this space here is largely empty, but sometimes fluid builds up here. And so you'll do a pericardiocentesis, which basically means that you get a needle and you actually draw fluid out from this area like right here. And it's fine. You're not actually hurting the heart or the lungs because this is kind of considered, let's call it like a dead space. Basically, it's empty space. So that's actually where you would perform a pericardiocentesis someone with perfusion. But that's basically, I think that is the last thing I want to say about that, the how you diagnose it. You can also diagnose it using a biopsy, because if you do a pericarditis, you get fluid out, and then you can use that fluid to diagnose if it's a mesothelioma. You can also do a biopsy, which is actually important for if you want to do a histological confirmation. Remember, biopsies are how you can see, you cut like sections of tissue and then you look at that tissue under a microscope. Remember those microscopic images I would show you? Like here, this is a histological slide, that purple slide. So that is actually how you could also diagnose it. And since this is a type of cancer, you can actually stage it with a CT chest and upper abdomen contrast and know what stage this cancer is. You can also use a PET CT or an MRI with contrast in order to be able to assess tumor invasion. And how you would treat it, you would actually treat it with chemo, with systemic chemotherapy. That's actually the primary treatment for most patients to improve quality of life and survival. And then you could also do something called surgical cytoreduction. That's another method for patients with localized disease, as long as it hasn't proliferated or become malignant to other places and traveled there. You could also do a pleurectomy with uh, basically you can take out that part of the lung, and it should be good, but of course you would have to, every patient is different. That's why there's a lot of different types of treatment options. There's also an option for adjuvant radiation therapy for selected patients as part of like a multimodal approach. But the prognosis for these patients, or like basically what is life like for these patients, is generally poor because the median survival is around 1 year for unresectable mesothelioma, because you're not able to resect it if it's connected. Remember, this is the mediastinum is connected to arteries, veins, nerves. Um, so if there is a mass and it progressively gets worse, because about 50% of the cases of mesotheliomas, they actually metastasize. So common causes of death include like a pulmonary embolus, like you could have cardiac tamponade, invasion of the great vessels, and also cachexia. So and this is not a disease with very good prognosis, and that is why people are working for cancer cures, and this is one type of cancer. There are many types. Now we're going to discuss very briefly a couple of case studies that we didn't get to last week. So
Pretty quick, I want to go over, as Kenan mentioned, he has asthma since age 4, and I asked him, and he's using inhalers. So pretty quick, I want to talk about asthma, like it can be categorized into different types. And so for Kenan, you can see, because asthma can be intermittent, it can be mild, moderate, or severe. So you can categorize which category you are on, how often you're using, because everyone has a different treatment. And basically, researchers have categorized inflammation in the airways with asthma into 4 biological ways, pathways. And it can be including eosinophilic, neutrophilic, but I will not go in much detail. I will just go pretty quick that you can assess if you have a mild, moderate, or severe. Based on that, I hope your physician already talked about it, so you can learn more about asthma and how you can manage the and the your symptoms. And of course, it's a chronic respiratory disease that because of the inflammation and narrowing the airways, making it difficult to breathe. But if we use inhalers on time and use appropriate inhalers like bronchodilators, sometimes for severe cases, we need steroids. So it will help you with your symptom and with the quality of life. Thank you.
Sorry, I was looking for my unmute button. Thank you, Dr. Chima. I appreciate it. So we're going to be going over one case study today. And does anyone want to volunteer to read? Okay, I will read it. A 27-year-old woman comes to the physician because of a 2-month history of increasing shortness of breath and a non-productive cough. She has been unable to perform her daily activities. She has also had malaise and bilateral ankle pain during this period. She first noticed the symptoms after returning from a vacation to Arizona. She is a research assistant at the university's geology laboratory. She was born in Nigeria and visits her family there twice a year, and her last trip was 3 months ago. So the patient's temperature, 100 degrees Fahrenheit, pulse 100, respiratory rate 24, breaths per minute, blood pressure 112 over 72 millimeters of mercury, and O2 saturation was 94%. There's no palpable cervical or axillary lymphadenopathy. The lungs are clear to auscultation, and examination shows ciliary injection and photophobia. Sorry about that. And photophobia of the left eye. The remainder of the examination shows no abnormalities, and a complete blood count is within the reference range. An X-ray of the chest is also shown. So which of the following is most likely diagnosis? So I'll show you all the chest X-ray first. But basically, in this question, which of the following is the most likely diagnosis? The options are sarcoidosis, pulmonary tuberculosis, hypersensitivity pneumonitis, Hodgkin lymphoma, or histoplasmosis, and granulomatosis with polyangiitis. So we did not go over every single one of these diseases. Actually, we did actually briefly discuss Hodgkin lymphoma and hypersensitivity reactions. So, what does everyone think what this question could be? Basically, I also highlighted the important parts of the question because sometimes they give us unnecessary information, and our job as test takers are also to be able to tell what is important and what is not important. Because remember, patients, you need to be able to differentiate between important history that they give you and sometimes not important history. Of course, all of it is important to be able to tell diagnosis. So here I highlighted shortness of breath, non-productive cough, ankle pain, photophobia of the left eye, and X-ray of the chest. So I'm looking at the chest here. It looks very, very similar to something that we've seen already as well. So the correct answer is sarcoidosis. You can see here in the chest X-ray, the lungs have a pattern of innumerable small nodular opacities, and the hilli, they're enlarged and lobulated. You can see in the red overlay here. And the right tracheal stripe is also widened, and that's the green overlay here. So that's sort of what people see when they're looking at chest X-rays. It sort of looks the same, but when you are able to actually point it out as I'm going back and forth, you're able to actually see it now because I highlighted it, so it's easier to see. So and the bilateral hilar and the right mediastinal suggestive of sarcoidosis, and also referred to as the Garland triad or 1-2-3 sign. And remember, there's an involvement of the eye, ankle pain, a non-productive cough, and also the chest X-ray. Finally, that confirmed it for me, seeing those things, and also seeing, oh, wow, there's so many organ systems involved here. Right? Why are the eyes involved? So there's only one disease I know of right now from our session today that also involves the eyes, and that is sarcoidosis. So I'm going to wrap up our session for today due to time. So I wanted to actually, the TeleShadowing session quiz will be live shortly. It's not updated yet, but you can take last week's session. It'll stay open as well as this one, and we will send it out via email later today. And thank you so much, everyone, for joining today's session, being very active and participating, asking questions. Feel free to ask any more questions you may have at learn@teleshine.com. We are more than happy to answer any of your questions and clarify anything that we learned today. So remember to access the quiz at teleshine.com/certification. We hope to see you at our next month's sessions.